when they are acetabulum or the top where the head of the femur fits and the hip bone is very shallow. So that makes it that the hip bone, the head of the femur can fit in that cup, but because that acetabulum is so shallow, the bone will bounce back and forth from it. So, which is what you will see on here as compared to here where the acetabulum is well nice and curved and inside as it should, but here it's so shallow. So another thing that happens is that there is that laxity of the muscle, the ligaments that makes it to be so lax. There is that subluxation and there is a dislocation. It can come out completely. So those are the three things that you will notice when there is the dysplasia. Three of these things can happen. Okay. So, but when you look at this one, the head of the femur is nicely fitting in that cup and it's secured and well attached, so it has no little or no movement. But here, there is not a way holding it straight, and it's like a loose connection. So, how do we diagnose that? Of course, the first thing you know, and you've noticed this in your newborn assessment, the immediate newborn assessment will be your ortholearning test when you do the hip flick. I hope you remember that. Okay. Or you do the Barlow's test. Ultrasound can also be used to diagnose that, and you will see the system on the ultrasound. But in older children, they will use X-ray, and where in the X-ray you see that if you look at the X-ray of the hip, you see the deformity in the X-ray of the hip. How does this manifest? Of course, in the infant, you will notice that one limb is shorter than the other. Like I hold this infant up, like this, I will notice that you see this leg is longer than this one. So you'll notice that on the affected side. Other things you can notice in the infant will be that there is a restriction on the hip, the abduction, which is stretching this way, abduction will be this way. ADD and abduction of that hip will be restricted when you try to do that. That's what you are really doing with your ortholearning test. And you try to see that, so you do the restriction on that. Another thing that you will notice will be the gluteal fold. You see that it's unequal gluteal folds on the affected side as compared to the other one for the infant. And then of course your ortholearning test or your Barlow's test will be positive. In the older infant or a child, what you will notice will be, again, the affected leg will be shorter than the unaffected one. You will also notice there is telescoping of the there is telescoping or pinning of the hip joint, like when the child, like here, when the child is moving, the head of the femur bounces out. You will see that out protruding towards the side of the affected hip. That usually you do not see it in the infant because they are not mobile. But this is a child that is walking, so as they walk, you see that bouncing back and forth. So that is one thing you notice in an older child, or a child who can walk. As they walk, you see wobbling. There is also the transdermal sign for the infant, for the older child. Also, you will notice that the greater trochanter appears prominent, and it aligns in the anterior superior iliac spine. Other things that you may notice will be there is we talked about the lumbar spine when the shape will now change from a convex to a concave. You see that in the child that has hip dislocation, there is marked lordosis, curvature, inside curvature of the lumbar spine, and then the waddle as they move around, so that the leg is just wobble as they move around, especially with the bilateral one. So, how do we treat this patient? Early identification is our goal, and that was that we would want assessment for us to help us to identify those kids that have congenital hip dysplasia. We'll use plates to put the hip in place. So what we're trying to do is to adopt up down, not as will make it look like this, and then we'll dislocate more. So you want to spread the leg and hold it in place. Hold the head of femur closer to the acetabulum or the socket as closer as you can, and then allow it to come down. And they can achieve that by using the fabric harness to maintain that flexion and abduction. One thing the newborn, the labor and delivery nurses do, immediately they notice this, they will use like double diapers to achieve that. Initially they will do that, okay? But putting this child in that's where you would like to call that child. Again, if that harness is not used, or for an older, they can use the cast as well to form a hip spiker, meaning that they will put the cast in such a way that it looks like a pant for the child. So they will do the manipulation and then put the cast, use the cast to form something like this as well. So the child will have the cast, it will start from here and then will end on both legs, maintaining the position that we want. So in either way, parents need to be taught how to maintain the cast and or the harness. Okay. They will always also need to know of the signs and symptoms when we want to watch out for the neurovascular assessment on the extremities. Other things that the parents need to know about would be, especially if they are diapering of the child. So the child has this cast, but they'll have to open up an area in front and an area in the back so that the child will be able to do toiletry on the child. So they need to still give the child their ADL and be able to maintain the skin integrity in those areas. Okay. Changing, yes.
But how long is that supposed to stay on, the fabric, like all day, or how long will it stay on?
Usually it stays on and then you have to take it on and off to give the child, bathe the child, do skin care on that child. But with the hip spiker, you don't take the hip spiker off, except for when they go to their serial casting. So, but you have to give the parents how to give the area of care, wash the patient around that area, maintaining the skin integrity around the open area, because they would open areas that will be able to still care for this time. So again, we would like to maintain, prevent our injuries and teach the parents what they need to do. Other problems could be when the tibia goes, and you see that curvature, see here, that is going, and usually for children, at the initial time, as they're growing, their leg is kind of curved, but as they grow, as they develop, it strengthens a little bit. Sometimes it does not stretch properly, and with undue force, it curves some more, especially in obese adolescents, especially the African American female. You see that with teenagers, you see them with that problem. So what happens is that you will notice that the knees are widely separated as opposed to the knees being, when they are straight, they are almost in alignment. They are not, the gap between the two legs, when you place the two legs together, it's approximated, but when they have tibia varus, they put the legs together, but they still have that gap because the two knees are separated. So you have that saturated gap between the legs when you put the ankles together. Okay? And the legs are turned inward. As opposed to a normal leg, they do get straight and everything. But as opposed to go this way to get this. So again, for this, we can do bracing for the minor ones, or casting. And when that fails, then they have to do the surgery to correct it and then put the cast to put it in place. Rickets will be another problem when you have bone demineralization. There is less calcium and or vitamin D to solidify the bone, so the bones are soft. Again, because there is lack of calcium and or vitamin D and or alkaline phosphate deficiency, we need to reintroduce what the person is lacking, as we did with endocrine disorders when there is lack of one enzyme or the other. This is basically what we're doing here. So we replace the supplement by diet, and then we would like to use this to support the extremities as the bones are formed. Sometimes they may have to do surgery to correct the deformity, and post-operatively they are still giving the supplements to help solidify the bone. And again, whatever appliance the patient has, cast, or whatever we have to do to get them on that as well. So a problem that happens also with in the child that is acquired is that the child is born normally, the bone develops normally, and for some reason there is no more blood supply to the head of the femur. Just for some reason it happens. The head of the femur loses blood supply, and becomes necrotic. And once that happens, there is no longer blood, so that will lead to pain, and that will lead to discomfort in the child. Peak incidence of this happens in children between the age of 4 to 10, but the peak is 6 to 9. And documents have shown that it's more in the boys than in the girls, but not to say that girls do not have it. Girls still have it, but it presents more in the girls. Some of them can affect both hips, but for the most part, it affects only one side of the hip, but it can occur bilaterally. So once there is that cut off of blood supply, there is nothing, the head of the bone of the hair of the femur just dies off because it's necrotic, no food supply, no nutrients, no blood, no cells, no tissue, no nutrients. It dies off. And this happens most of the time. The children or the child have no clue what happened to them. All they will know is that one morning, they'll start limping because of that pain on the affected side. And you ask them what happened to your leg, have no clue what happened to them. No history of trauma, no nothing. They don't know, they don't record anything. All they know is that they feel that pain in the hip. And with that pain, once they start to move, as with each movement, the pain will increase and will be relieved with rest or when the child is not moving. So if this is identified on time and taken care of, then the child will have a good recovery from it. But one thing we know is that as the disease progresses, as there is total or complete loss of blood to the head of the femur, it becomes necrotic, it will diminish the movement and range of motion to the affected extremity, and sometimes if it is bilateral, that child has really limited mobility. If it is one side, then you start, the lack of use, muscle atrophy, and all the consequences of immobility, non-use of an extremity will start occurring on that affected side. So, we would like to identify that problem, and they can see it on X-ray or MRI. So, strategy would be to rest the affected area. So the physician will order non-weight bearing, so the child will be taught how to use crutches, and they love it. They can fly and do acrobatic dance on their crutches and do everything. Okay. But the downside is that the conservative method is that it takes so long, and compliance of the child is questionable. Because sometimes they will forget themselves and just say, what the hell is this? Put the crutches down and then run on that and then bear weight on it and then aggravate the problem. And once they finish with that activity, they can no longer move. Okay? So that becomes a problem, it becomes an issue with that. Other things that can be used besides the non-weight bearing and use of crutches, they can put the patient on traction. And of course, if you put the patient on traction, now you are immobilizing the child and further complicating their issue. This is the child. Remember the age group we are talking about tends to, they like to move, and then you are confining them to a place. They will not be happy campers for you. And then all the consequences of immobility. Okay. So, some or most orthopedic surgeons these days would opt out to go for surgery. And once they do the surgery, they just take the place that you know you can do hip replacement on the children as well, just replace that affected area head of the femur, and that eliminates the problem quickly, and the recovery is fast as well. But the first line of treatment will be the conservative method of weight bearing, non-weight bearing, to see if the blood flow will resume in that affected area. So again, we need to identify those kids and refer them, and also be able to do our teaching, including the post-operative care that we give when they do surgery for the child. We need to educate them about that care of the breast and all the tasks if they wear one. Okay. Another condition that really mimics this particular leg surgery disease is that slipped capital femoral epiphysis. For some reason here, the epiphyseal plate on top of the femoral bone will just slop off. With the leg surgery, there is no blood supply, and the head of the femur will die off. But this one, there is blood supply, but that epiphyseal plate will slop off due to hormonal influence. And once that slops off, there is now a lot of stress directly on the bone itself. So now it's bone rubbing to bone. Okay, so with that weight bearing, the child will complain of pain again. So this one, they will want to go into surgery and then pin back the block epiphyseal plate, or they can just do a removal of the femoral neck and do a replacement for it. So the type of care you will see that same pain, the child will be complaining of pain, non-use of the affected extremity, and also you see that problem on X-ray. And here they can use traction again as with the other one, or they can do surgery to refix their slip epiphysis, or they can do a replacement. In short, what they do is the same, very similar to what they would do with leg purchase disease. The only difference that you will notice will be the position of the problem. The other one, no history of any trouble, injuries or anything. For some reason, lack of blood supply. This one, due to hormonal influence, the epiphyseal plate slops off that covers the head of the femur, and that causes pain. So that causes disuse. So both of them will be repaired and the child will be taken care of very soon. Any questions on those two? But they're both pretty common in children. Okay. Another problem will be the scoliosis, which is the most common spinal deformity that occurs in children. It can be congenital or it can be acquired. when it develops during childhood. But generally, it is noticed during the middle school age group, and that's one of the things that they'll have to do in terms of screening for the child. But the number one complaint that the patient will present with will be that, oh, gee, for some reason when I put on my t-shirt or my clothes, it doesn't fit right away. It fits awkwardly. There's always a bulge somewhere or to the side. That would be the number one complaint that they will. And then when you look at them closely, you'll be able to see the discrepancy in their coverage. Also, you can come with that. So, majority of them have no cause, but some could be due to a muscular disease, or in our patients with congenital problems like cerebral palsy or that can have, or muscular dystrophy or myelomyelitis can have that curvature. So what you see is that curvature of the spine. Look at the spine is very curved. You see the rib hump. When you look at the person, you see they are asymmetrical. One shoulder is lower than the other one, an even shoulder. You turn their back, you see that their scapula is uneven. There is kind of uneven hip when you look at their hip also. And then there is a leg inequality as well. So, for scoliosis to be present, when you look at this one, like in number one, you see this hump here. There is a hump on the back when you ask them to lean forward. And this here, the person is trying to confirm that by putting a ruler, and then you see that it's tilting because of that hump. Second, there is this discrepancy in the shoulder. One shoulder is where that curve is. The shoulder is lower than where there is no curve. You look at the waist. There is this protrusion on the waist to form that C. Concave. And on this side, you see that the hip is quite another, but that one is kind of exaggerated. And that's because they hip to tilt. And the scapula is more pronounced on one on this side as opposed to here. And one, this arm is shorter. Look at where this one is. So, how do we manage it? Well, the management is a team approach. We use both braces, exercise, and surgery, depending on the severity. For very mild curvature, and this will be curvature that is described at a degree of up to 10 to 20 degrees of curvature, will be very mild. And usually the orthopedic surgeon would like to do exercises to improve the muscle tone and to improve the posture and strengthen the muscle so that the curvature will be able to decrease. So so in other words, their strategy is to build strength on the spinal muscle on this side of the curvature, to build strength of these muscles on the side so that they can pull their curvature backwards in alignment. And once they are doing that, they would like to follow up with this child at least every 3 months. But the child will have continued to go to their physical therapy and do that. But to see the physician, they like to at least every 3 months, and they will also like to recheck what is going on X-ray. However, if the child progresses to a moderate curvature, meaning that curvature that is up to 20 to 40 degrees, okay, this is the time they will wear their braces to maintain the alignment, but note that the braces do not correct the deformity. It does not correct the deformity, but it just maintains, they use it just to strengthen strengthen themselves just to maintain that deformity, okay, to stop it from progressing, to stop it from getting worse, but it will not correct it, okay? So, ideally that person should wear that brace for 23 hours. That's the recommended time. Treatment for this is very lengthy. And we're talking of adolescents that are concerned with this problem. And you're telling them you have to wear this thing for 23 hours a day all the time for only God knows when, and they're going to wear it. Of course, they will wear it for a while and they will become non-compliant. And they will not wear it. So that is a problem. Something that they are doing also would be at times for this moderate curvature, they may do electrical stimulation of the muscle. And that will use the electrical current to stimulate the muscle, so make it to kind of contract, and that will help it to correct the curvature. But that they don't use it so commonly. It's something that on the side that they do, and that they will have to do the electrical stimulation at night. Okay. But surgical intervention is indicated for very severe curvature when the curvature is above 50, between 40 and 50 or more degrees. So they'll have to do the spinal fusion. Usually the first ones that they use, there are so many of them, but the first ones they use was the Harrington rodding or the L rod, which kind of took the name for the procedure. And what they do is to put the rod in place, and then they'll still have post-operatively have the person wear the braces. Immediate post-operatively, after the spinal fusion and insertion of the rod, this person needs to be, pre-op first. Pre-operatively, you need to prepare the patient with everything you record that they do in pre-operative situations, from the consent and all that. But in addition to educating this patient on what they need to expect in the immediate post-operative period. This patient will have to be recovered or will be treated for the first few post-operative days in their intensive care unit. So you need to let them know about that. When they wake up, they're going to have a Foley inserted if it was not done before you put them to sleep. Okay? They will also have to have an NG tube in place when they wake up, because you will need to decompress the stomach post-operatively. So you need to warn them ahead of time that this is what is happening. This is what will happen. In addition to that, you need to warn them as well that immediate post-op period until they are allowed to move on their own, they will require you and several others to log roll them. So it means that you need more than 2-3 people to change their position from side to side. So in other words, this is not, you cannot afford to bend their back, so they will have to change their back on as a log, roll them. So they know that way when you start doing it, they are compliant with what you are doing. Okay? So, because you still need to maintain the skin integrity, and you still need to reposition this patient. Okay? So, for them to get up, it needs a physician's order to do that, and the physical therapist usually will be the first out of bed to cheer. Most of the time now, they are allowing them to get out of bed to cheer within 48 hours, depending on how that patient is doing. Some of them could be longer. Okay? Other things you need to do for this patient post-operative, you will include monitoring that incision site, because they have the incision from top to back or on their back with huge dressing and possibly a drainage. It could be vacuum drainage, it could be frac drainage. Okay, so you need to monitor all that. You need to monitor their vital signs, and you need to assess for pain and medicate them for pain. In addition to doing their intake and output and all that, measuring the NG tube and all that. So, you will do that, and then you have to take the patient fully. Any questions on scoliosis? Okay. So you know that braces does not correct the curvature. It does not, it's not, it just halts the progression, and they need to wear it for most of the day, 23 hours. Okay. For adolescents, they need to wear their braces, wear a light t-shirt underneath before they put the braces on. Thank God these days they have like a low braces. Before it was this huge one that starts from the neck and they put on their braces, their dress is sticking out. No, these days they're wearing one that is just below their breast line that you can hardly tell that they have anything on, and that is making them more compliant to the treatment. Okay, so you have to treat their psychosocial and emotional issues that come along with that. Okay. Any questions? Yes? No? Okay. All right. Another thing we have would be the infective ones, and common among that would be osteomyelitis, which is an infection that can involve the bone, cortex, or the marrow. Chief causative organism would be the staphylococcus, or could be any other infection. It can occur by trauma or when bacteria enter through blood supply and gets into the bone. Okay, once that happens, it's very, very hard to heal. to treat. So in infant, of course, we notice all these vague, non-specific um, symptoms that we notice for any other thing. But the diagnosis would come from doing a blood culture, and or if there is any drainage, if there is a sinus anywhere on the when you see it draining, and then we take the culture of that drainage and we try to isolate the organism that is affected. So for the older kids, this is they will complain of pain and limited range of motion, which is inconclusive until you do your definitive diagnosis to say, okay, this is what it is that is happening. Because they'll have to rule out every other thing, including ruling out leukemia, when they're presenting with that kind of symptoms. So, treatment is by high dose of antibiotics, and we'll have to mobilize the affected limb by putting a brace and or a cast to help rest that area. Then we need to educate the parents and or the child about the need for the IV antibiotics. So they'll start it in the hospital, and then they can go home on IV antibiotics, which means they are going home on central line, which you need to care and tell them about the central line. The nurse, infusion nurse will come at home, teach them, and then the parents will continue to give them, because they think about it, giving it sometimes over a period of 6 months, they'll be more. Okay, and they'll have to come back for their follow-up. Again, don't forget about the nutrition and all the things that we talk about. Septic arthritis, as the name implies, is infection of the joint by bacteria. Again, our friend staph, or it could be Haemophilus influenza, or it could be strep. Again, we're looking at IV antibiotics to treat it. And then we're also considering, giving anti-inflammatory like non-steroidal anti-inflammatory medications, or we're giving also some steroids to help with the inflammation. Of course, most of these standard ones will be self-limiting, and that will be kind of okay. So, any questions is not musculoskeletal in the first system is just like a kid, because we do most of this that we talked about children with sclerosis. But any question on musculoskeletal? So, basically I brought this up here because we will be going to children's specialized hospital, and these are the kids that we see in the acute care that are going to evaluate for some form of illness. And we'll define a chronic illness as any condition that lasts more than 12 months. It can pose a physical, psychological, or emotional or cognitive impairment on the child, and the child will require assistance to live their day-to-day normal life. And I gave some of the examples of what can constitute a chronic illness. But the goal for this long-term care that we will bring in children's specialized hospital would be, we would like to achieve and maintain normalization in the family. Yes, in the face of the diagnosis of the chronic condition that within the child, we would also like to maintain that child's normalcy. We would like the child to maintain the highest level of functioning as permitted by that particular disease process, and or the deformity and or the discomfort that the problem is already trying to cause in the child. Okay? In other words, the family we want them to be together, we want them to be intact, but does that happen most often? You will notice that once a chronic illness is involved, that the stress of taking care of the child will tear the family apart. The father will just pick up his suitcase one morning and then walk away, or the mom will just say, forget it, I'm not part of this anymore, and just, or both parents will just say, you know what, I can't do this, the government take care of the child. This has happened before. So, all through you see how it affects both the infant and the toddler, and strategies that you will use to kind of care for them, or things you have to bear in mind how to resolve some of these issues that happen to them. Or the preschool child, how the illness affects them, and also strategies that we can put in place to help resolve some of these issues. And then the school age child, their issues, and all this is stemming from their growth and development of things that you know they will normally do, and then how you can address some of those issues. Okay. For the adolescents, the same thing. Okay, and how you will address them, the issues, and how you will get them involved into their care. Now, for the siblings, we know once the child is sick, what about the other children in the family? They have, besides their age, specific, they also have some resentment on the child that is sick, and this is some of the strategies where we would like to, because our goal is to maintain that normalcy in the family. And then this brings us to when that child is so sick and the child will know that we have to kind of conserve the time, and we have to take that child, and we come to know that yes, we have to, and there is no more that we can do for this child. The child has a chronic condition, and we transform that mode of palliative care, especially those of them that are diagnosed with leukemia, because we went into remission and then relapse, and then what is left more for them. So that's when we fall into this, or even with traumatic injury, we know there is something going on with the way the body is going on. So we have to define that palliative care as an approach that provides a compassionate and supportive care to the families of children with life-threatening conditions. Okay, it does not hasten or postpone death. Rather, it provides relief for innocent. So right now we're focusing on the symptoms that they are presenting to get that child to make that family more comfortable. Hospice, on the other hand, which is very similar to palliative care, is the same. However, hospice will come in place when it has been determined there is no more cure possible for this person. And it needs two physicians to satisfy that is happening. The attending physician is the pediatrician, and then the hospice physician to satisfy that there is no longer cure, or maybe the cancer specialist, oncologist, and the pediatrician, and then the hospice specialist will say, okay, no, we know what we've done, everything we can possibly do. And we know this is not an easy decision for the parents of the family of the child to take. So, but then this is something that we have to show it out to them, and this is what we do that for the child. Okay? So, this is comparison of hospice, what is palliative care, and how we use it, so that you can just know the differences. Okay. Okay, so both of them will do almost the same, but the major difference is the multi-sacrifice and the prognosis is the life expectancy is very different. Okay, so this aggressive comfort treatment is something used specifically in teens. We can see this also now, those of them in adulthood stage, they are reporting this as well. Rather than give a child the status of a DNR, which you will see more of in an adult, we write to put it as aggressive comfort treatment. So instead of saying we will not resuscitate you anymore, yes, we are not doing aggressive resuscitation or calling the phone or doing all that for you, but any symptom that you present, we try to treat that symptom. Okay? And that's what we are focusing on the child, and we will not put it down as do not resuscitation. But they will not do things aggressive as to give the chest compression, but they will try as to presenting, make that child very comfortable. So that's what they are aiming at, and they mimic that and parents see that as you are doing everything possible for this child, even though you are not integrating, you are not doing all that, putting all those bells and whistles on this child, but you are doing everything possible to get this child comfortable. So to take that, that is better than the taking a DNA. So that's what, and that would be things that we do. So in general, the goal of end of life care would be to control those symptoms, to identify the trend, and provide that meaningful interaction between the child and their family members. That way, if eventually they die, they eventually display them. Some of these barriers that you can afford, and then of course we define death and how you care for your death. Again, professional, especially in children, this is an issue for us. Once we know this child and we're taking care of this child, and all of the things we know that the child is dying, most of us don't take it lightly, and it becomes a very big issue and things for us. And that brings us that we need to know we need bereavement when something happens to a child that we are carrying. So these other concepts. So again, it's professional view as a nurse, taking care of, we don't know this child from Adam, but because they are your patients, they are now yours. And we refer to them as my baby, my boyfriend, my girlfriend, anything we can use to refer to that child, and we have this attachment to them. And anything happens to them, most of the time we take it personal. And that comes to the need that we need the support for those that work in intensive care unit, for those that work in oncology unit, because they burn out easily and they need a debriefment after something happens. So they need like counseling and support for each other when anything happens to them. Okay. Any questions? That? Any questions on that? Yeah? Yes? No?